Hi, my name is Connie Koklanis and you're watching the video on the Prism Adaptation Test. The Prism Adaptation Test is yet another clinical investigation that we can perform to allow us to gain some information about the potential that a patient has to achieve BSV. However, the PAT does do a bit more than just tell us about the potential for BSV. It actually is useful in predicting the outcomes of surgery, and it tells us or gives us information about what's likely to happen to the visual axis post-operatively. So is the patient potentially going to be straight, or is the patient potentially going to revert to the original angle of their deviation? It's mostly performed in patients with acquired ectopic deviations. However, you can do or perform this test on any patient that you are suspecting may have a poor post-operative outcome, particularly if you suspect the patient has a history of ARC or abnormal retinal correspondence. Now, to understand the Prism Adaptation Test, we first need to understand Virgin's adaptation. So let's go over that first, and then I'll take you through the procedure for the PAT and what the likely outcomes are of the PAT that suggest whether you're going to have a good or a poor prognosis post-operatively. Now, so far in your studies, you've discussed the different types of convergence: voluntary, tonic, proximal, accommodative and fusional. And in relation to fusional, we've talked about motor fusion and sensory fusion. What we haven't really discussed is another two types of fusional vergence, and that is fast fusional vergence and slow fusional vergences. Let's go over these. The fast fusional vergence, or the fast fusional vergence system, is essentially induced by disparity. And it's the system that initially takes place to realign the eyes. And it's a fast system, as the title suggests there, and it happens and occurs in less than 1 second. So if you can imagine, if I put a base out prism in front of a patient that is bifoveal, that patient will make a fusional convergence movement to realign the eyes. And the driving force for that fusional convergence movement is retinal disparity, is that diplopia. That is the fast fusional vergence. That first response we see to the prism being placed in front of the eye is considered fast fusional vergences. It's a burst movement that moves the eyes to correct the vergence position. Now, the output and the effort of this fast fusional vergence system then acts on a slow fusional vergence system, which adapts to fusional demand. This is what takes place in order for us to maintain comfortable BSV. It resets the level of tonic vergence, and it's much more efficient at maintaining a particular vergence position, and as a consequence it results in less fatigue. So overall, the slow fusional vergences relieves the stress from the increased demand of the prism on the fast fusional system. With the relieving of this stress, it also makes it possible for the fast fusional vergence to respond to a subsequent stimulus of disparity. Let's look at an example to gain a better understanding of vergence adaptation. And we'll look at an example by Carter, which is in your notes on LMS. And here we're given an example of a patient at baseline where a cover test is performed, a left hyperphoria is detected, and it's measured to be 1 prism diopter with a prism cover test. Now, let's say that a 1 prism diopter is prescribed and placed in front of the left eye. Okay, this is going to induce a vertical fusional response. And you ask the patient to come back in 4 weeks' time. So here we have baseline plus 4 weeks. The patient returns, and the cover test result shows that there is a left hyperphoria of 1 diopter through the prism. So despite us inducing a vertical fusional movement by putting that 1 diopter base down, the patient has returned 4 weeks later with exactly the same phoria or measurement of the phoria as baseline. So on this occasion, an additional 1 diopter base down is added to the glasses, and so now the patient goes away wearing 2 diopters base down. Again, now we're going to induce further fusional vergence movement. Now we're inducing an additional 1 diopter of fusional vergence. Okay, we then ask the patient to come back in another 3 weeks. Patient returns, and they return with a left hyperphoria of 1.5 diopters. So they're slowly returning back to that original hyperphoria of 1 diopter. What does this mean? It means that essentially this patient is masking a 3.5 diopter deviation. So at baseline plus 7 weeks, we're detecting a left hyperphoria 1.5, but it should actually be 1.5 plus 2, because we induced another 2 diopters worth of vertical fusional movement. But the patient has adapted and is returning towards their original phoria. Now, if you want to disrupt the slow fusional vergence movement, the way to do it would be to occlude the patient. So if you patch the patient, over time, the slow fusional vergence response will dissipate or decay. And if you bring back the patient after occlusion and they're still wearing the 2 diopter base down, then you should find 3.5 diopters of deviation after occlusion. But as to how long you need to occlude that eye varies. In some instances it might be minutes, in other instances it might need half an hour, hours or days to decay that slow fusion response. Now let's use a flowchart to describe what we've just discussed. So we start off with the patient who's bifoveal and may have a latent deviation. In the example we just discussed, the patient had a hyperphoria, but they could have an esophoria and exophoria. In any case, a prism's been placed in front of a patient who is bifoveal, and what occurs is retinal disparity, and in response to retinal disparity, first thing we note is a fast fusional vergence. Well, that's the first thing that takes place. And the phoria changes by the amount equal to the prism. However, what then takes place is slow fusional vergence, and phoria or prism adaptation takes place. And what we see through that adaptation is that the phoria returns to a pre-prism value. And this vergence adaptation removes the stress on the vergence system. Now below here I've given you some text from a study by McDaniel and Vogt, which describes again why that slow fusional vergence system is taking place and what the benefit is of the slow fusional system. So far the examples that we've discussed are with patients with no manifest deviation. So we have a patient who's bifoveal, and when we introduce that prism, a fast fusional movement takes place, bifoveal fixation is attained, and then vergence adaptation takes place. What now happens with a patient with a manifest strabismus? We've talked previously about the fact that when you put a prism in front of the deviating eye, it doesn't move. But the truth is that a manifest deviation, or a patient with a manifest deviation, may make a movement in response to a prism, but it takes time. And in order for us to see whether a patient with a manifest deviation will make a movement to the prism, we first need to give them retinal disparity, diplopia in other words. So we have to move them outside of their suppression scotoma and give them double vision. And usually this means overcorrecting the deviation, so taking them past their fovea and then giving them time to see whether any movement occurs. And that gives us the underlying principle of the prism adaptation. So let's move to prism adaptation test. So before I tell you the procedure, let's just talk about who can we perform this test on. First, we need patients who have equal or nearly equal vision, so a line difference as an example would be okay. The angle of the deviation shouldn't exceed more than 40 diopters, and generally it's best if there is no near distance disparity, which means that the near and far angle of the deviation is the same. So as an example, it's 20 diopters at near and it's 20 diopters at far. If there is a difference between the near and far angle of deviation, so say it's 20 at near and 30 at far, then in terms of what prism you're going to use as part of the Prism adaptation test, it becomes a bit more complicated. And it's probably suggested that you average that near and far and use that prism. So in that example I've just given you with the 20-30, you'd give the patient a 25. The other requirements are that it is best utilised in patients who have a stable angle and who do not have a vertical deviation as well. By stable, we mean that the size of the deviation is not variable. Okay, now let's move to the procedure. Let's take the example of a patient here who we have a 25 diopter LET. And we can see here, I've given you, this is the fovea here, CIP is on nasal retina, and the patient is fixing with the right eye. So as I said earlier, as part of the Prism adaptation, we want to overcorrect this deviation and give the patient diplopia. So let's assume that they have a suppression scotomy between fovea and CIP. So this 30 diopter prism will take the patient into temporal retina, will give the patient cross diplopia. And what we'll need to do is prescribe this prism, and we usually give patients Fresnel prisms, and we'll talk more about Fresnels in some coming classes, which are placed on top of a pair of glasses. In terms of how long you keep it on for, that varies. So you could do it in clinic and do it for an hour or two and ask the patient to return in a couple of hours. You could do 24 hours, ask them to return in a day, or you could move into weeks and so forth. Let's say now that this patient has been wearing this Fresnel prism for a few hours and they return to clinic for an assessment. What are the possible responses that I may see? What's favourable and what's unfavourable? Okay, so we have, as you'll see here, there are three possible responses that the patient may have which are favourable. And favourable, what I mean by that is that the prognosis is good post-operatively. But there is one potential response which is unfavourable, which indicates that post-operatively you're going to have a poor outcome. Let's go through each of the favourable responses. The first possibility is that the visual axes are now straight with BSV. So what that means is that this patient here, before they left your room, if you did a cover test, what you would find is an exo movement of this eye. Yep, because you've moved the image to temporal retina. So if you covered this eye would move in to take up fixation. So in this favourable response, what you would find is when you cover test them, there is no longer any exo movement. The patient appears to be straight. And what you now want to do is prove that they're straight in that position or binocular. And so you would confirm with something like a Bagolini striated glasses test, in which case they should have a cross if BSV is achieved. And so what this means is the patient has fused the diplopic image, has made a slightly fusional convergence movement and has become binocular. And so this patient has the potential for BSV post-operatively and should do well if surgery is performed. The other possibility is that the patient may come back and demonstrate a residual microtropia with BSV. So now, even though you made the patient exo with the base out prism, they return to clinic and they've got usually a micro-ESO, but you demonstrate that they have BSV, again, with something like Bagolini striated glasses. So in response to fusional disparity, what's occurred is a convergence movement, and the patient has attained binocular single vision, but is microtropic. The other possibility is that the visual axis remain overcorrected. What this means is that when the patient comes back, they are exactly the same as they were before they left your rooms. So you made them 5 diopters exo and they've come back and they're 5 diopters exo. Now, this is a good outcome as well, in the sense that post-operatively they're not going to have BSV, they don't have potential for BSV, but when you correct them surgically, post-operatively, they should respond well to surgery and not drift to a larger angle over time. Okay, and lastly, we have the unfavourable response. Now, for an unfavourable response, what we see here is that the patient reconverges to the original angle, and what we call this is that they're eating up Prism. What this means is, if we go just back to that example here, again, when they left your room with the frenal Prism on, they would have had an exo deviation of 5 diopters. Now, when they return back, if they're going to have an unfavourable response, with the frenal Prism on, you will find that they have, as an example, a 25 diopter ET or a 30 diopter ET. They're drifting back towards their original deviation. So despite the fact that you've overcorrected them, they're making this anomalous adaptation movement. And this is telling you that they're going to have a poor outcome post-operatively. So from one perspective, what that unfavourable response is telling you is that surgery is unlikely to be successful. They're likely to return back to their original angle. So if the surgeon operates on a 30 diopter ET, it's likely that post-operatively that they will go back to being a 30 diopter ET or maybe something smaller, but it's unlikely that they will have a good post-op outcome. Now, some orthoptists and ophthalmologists, when they have an unfavourable response, what they will do is continue to increase the strength of the prism. So say, again, we'll come back to this example. Say this patient with the 30 diopter ET returns back with an unfavourable response, and when they return, there's a 20 diopter ET. Well, then what would happen is that you put 30 plus 20, so you send them away with 50. Okay, so you just keep adding until you see that the patient provides you with a favourable response. And it's suggested in that instance that you operate on the larger prism adapted angle. So if a favourable response occurs with 50, then you operate on 50. Okay, not many clinicians perform the prism adaptation for this purpose or in this way. And it's primarily because the jury seems to be out in terms of the evidence regarding whether operating on the larger prism adapted angle provides you with better surgical outcomes. So you'll find that the majority of clinicians who do perform the PAT do so in order to provide the patient with a better prognosis, or I should say more reliable prognosis. And lastly, in terms of recording the PAT, what we want to know is what prism was put in front of the eye, how long you kept that prism on for, and what was the outcome or what deviation was present when you assessed the patient with the frenal on after adaptation had occurred or time for adaptation had taken place. So here we have PAT. The patient had a 10 diopter deviation after wearing a frenal for 1 week, and the frenal they wore was a 20 diopter base out. Now your notes will indicate that the patient had a cover test of an ET and it was 15 diopters, so you'll be able to see from there that the 20 diopter was an overcorrection. You don't have to give all that information on the PAT. What we want here is the outcome and what was actually given in relation to the prism. Now the second recording here is actually exactly the same as the one above, and we can see here that after a week of wearing a 20 diopter base out prism, an esotropy of 10 diopters was found. There isn't a conventional way of recording a PAT, but what you do need is to have those elements included: the size of the deviation, how long you kept the prism on for, and the size of the prism. And in this particular instance, the second recording is better in that we also have the cover test result, whereas here I'm assuming it's an ET, but it's not indicated, and that could be an esophoria. So it is best to also indicate what that deviation is. One other finding that should be included in a PAT result is the outcome of any binocular vision testing. So I would assume in this particular example that the patient didn't have BSV. However, if the patient did demonstrate binocular single vision, say on Bagelini striated glasses test post-PAT, then you will need to include that within this finding so that it was clear that the patient achieved a BSV response as well as a favourable response in the sense of the alignment of the eyes. Okay, that brings us to the conclusion of this video. Thank you for watching.